All right. Well, welcome everybody to our nightly roundtable. This is going to be a short one since it's Friday night and it's raining like all get up here in McKinney, Texas. And I want to make sure I don't lose the internet connection. But it coming full circle now with the roundtables that we have been talking about the last couple of sessions has been on toxicology. I've only included those toxicological topics that are likely to appear on the National Registry exam. Although the subject matter of toxicology is huge and can include aspirin, Tylenol, alcohol, street drugs, methamphetamines, cocaines, and such, most of them are clumped into what they call toxidromes. In other words, a class of medications or substances that are out there that cause same or similar type of symptoms all the way across the board. Methamphetamine, cocaine, heroin, hydrocodone, Dilaudid, and such like that with the narcotics, the sympathomimetics that I mentioned earlier. These are all toxidromes. And so when you study this material, just know the toxidromes, and there's only 5 major ones, including the organophosphates, that will be tested on. Now, we try to take the things that happen commonly, and so you're going to get called for an occasional patient, whether it's a child or an adult, for antifreeze, which is ethylene glycol. It's that sweet green or sweet blue, depending on what product that you buy, that you find disturbingly on a garage floor, that keeps the engines either hot or cold, depending on your environment. Ethylene glycol poisonings, there's about 5,800 a year that get reported to poison control, and probably times 2 that who have been exposed to some sort of ethylene glycol. So your role as paramedic is not only going to be to recognize a person who's going to be at risk for toxicology or poisoning from ethylene glycol ingestion, but in some cases, and it's a small number of cases, but it's still in a small number of cases, there may not be a need for transport. We'll go over some of that criteria at the very end here. So before we get started, I've got everybody here that I can see. And can anybody, or does anybody have any audio or visual issues that I need to address before we start? All right. Very good. Okay, so let's rock and roll. All right. All right. Let me move all this out of the way. All right. Medical and toxicological importance, the things that we worry about: ethanol, ethylene glycol, methanol, and isopropanol. Methanol, another word for methanol, is wood poisoning. Big thing you have to know about that: yes, it can cause death, but for patients who do survive, methylene glycol kills the retina. It kills all the rods and cones in the optic disc, the fovea, and places in the retina where we distinguish both color as well as black and white. Well, in this particular case, it poisons all of them, and so you get complete and total blindness as a result of methanol, which is irreversible and unfortunately not eligible for transplantation. Patients for a long time that turned to methanol alcohol only saw the word alcohol on the side of a wood barrel. Methanol used to be stored in wood barrels and such, and it's used as a cleaning solvent and such. And it can also be used to spread over plating and metals and such, and then quickly burned off with flame to take off whatever you're trying to take off. In most cases, paint, sometimes oxidizers and such. But methanol still does have a lot of uses. Ethanol, of course, is your regular bar, streets. Go to Specs Liquor, go to Goody's Wine and Liquor, whatever you do. Ethanol is the ingestible form of alcohol that everybody is aware of, sometimes painfully aware of. Now, isopropanol is a type of alcohol that we use both as an antiseptic as well as a coolant. You put it on your arm, it'll cool off the body. If you put it on a wound, it will sterilize the wound. It's 70% alcohol. 100% alcohol is not as good as antiseptic as 70% alcohol. It seems to be contrary to popular opinion, but it has to do with what alcohol does to the bacteria by making it shrink, destroying the cell membrane, and then the 30% water that is present rushes into the cell and blows up the cell. 100% alcohol will just shrink the cell, but there's nothing there to kill the cell. So isoproterenol, isopropanol is 70-30, and that's the best bactericidal combination of alcohol and water. The presentation today that we're going to talk about is ethylene glycol, which is antifreeze. And the ingestion of ethylene glycol can be fatal. Not so much the substance itself, but once the body gets a hold of ethylene glycol, it converts it to other toxins. So antifreeze by itself is not per se poison, but what the body does with it turns it into a horrible poison, which is then fatal to the unfortunate person who ingests. So big, clear distinction. One of the reasons why pets do pretty well with it is that their livers are just a little bit different, cats and dogs both. They may lap up a little bit. Sometimes it does kill them. For the most part, pets do pretty well with it, but they're attracted to it because it's pretty, it's green or blue, and it actually tastes sweet. Okay, so it's antifreeze, and boiling and freezing points are all a big part of it. Fluorescence. Fluorescein dye is added to radiator fluid to help mechanics identify the source of a radiator leak. So that's why it's a pretty blue or it's a pretty green. Normally it looks like water, just like everything else in the world does. But they add the pretty blue stuff, and the beauty of it, although not horribly reliable, it's fun when it happens, is that when a person swallows or ingests ethylene glycol, we get them into the emergency department, put a Foley catheter on them. And when we take that Woods lamp, when we take that ultraviolet lamp and shine it on the Foley catheter, it lights up a very, very bright yellow. And in a darkened room, it'll actually light up the room. I mean, it's not going to be a ball field, but you'll be able to see that, the room is lit up significantly just because of the fluorescein dye. It's actually quite interesting. All right, the problem with ethylene glycol is that once it's ingested, it has to be converted to its toxic substances, and that can take anywhere from 2 to 6 hours, and sometimes up to 12 hours. Let's see, Jonathan, I'm picking up feedback on your microphone. Man. Yeah, no, it happens. My microphone's probably the lousiest anyway here, so I probably picked them up because I got a cheap microphone. All right, after a period of time, after they swallow this, they don't act intoxicated. They don't act, like they're falling down all over the place and such. It does satisfy their need for alcohol for the moment, especially in chronic alcoholism where patients are craving any kind of alcohol to stay out of DTs. However, at some point, they start developing mental status changes and then shortness of breath and difficulty breathing. Classic profile for metabolic acidosis is the same as it would be for diabetic ketoacidosis. You're going to get an altered mental status patient who's got some degree of Kussmaul respirations. And so what we want to do, just an overview, when you got metabolic acidosis, it leads to renal failure. And of course, what do you want to do? You want to start an IV and start dumping 500 cc's an hour at least, and sometimes a liter an hour into these patients and get them hustled into the emergency department. Now, testable items. This slide is going to be very important for you from a national registry test standpoint, because every once in a while they touch on pathophysiology on the national registry. And although they may not address things as enzyme alcohol dehydrogenase or glycoaldehyde, they're going to tell you that there are enzymes that are in the liver that are necessary to make the conversion. Alcohol dehydrogenase breaks down ethanol. Unfortunately, one of the things that it breaks down ethanol into is formaldehyde. And if anybody's ever been intoxicated in their life and woke up the next morning feeling like hell with a headache, it's the formaldehyde component of the breakdown of alcohol that causes the bad symptoms. And enough formaldehyde can cause nausea and vomiting up until the time you're able to clear the formaldehyde, which is generally a full 24 hours afterwards. So how do you prevent that? Don't drink. There's no other way to prevent it. We don't have any magic substances out there. Flushing a patient out with IV fluids and such can expedite the process. So you'll see some days the next day when patients come in the emergency room, nausea and vomiting after binge drinking. I'll put a couple liters of fluids into them, tuck them in a corner for a couple hours, and give them some Phenergan to help with their vomiting. And we check on them, 2, 3, 4 hours later to see if they've gotten any better. Although it's a nice way to get over an alcohol intoxication or a hangover, the emergency department plus IV fluids plus my fee turns out to be a pretty expensive evening for the patient. So through the interaction of all these enzymes and such, and I'm talking a little bit long on here to give you an opportunity to kind of sort of study the slide carefully, but just to give you background, there's a profound metabolic acidosis. I can get your pH down to 7.1 pretty easily, and it's because one of the breakdown products is glycolic acid, and this is testable. Glycolic acid in circulation is a highly acidic substance, pH of 2, pH of 1, something that you only find in the stomach. And when it starts circulating, it really, really starts dropping the pH down. And this is what causes a lot of the renal issues that a patient has. Once the glycolic acid is fully circulated within the body and it obtains what they call a large volume of distribution, another set of enzymes come in and turn into glyoxylic acid and then oxalic acid, and this is the terminal event. Calcium oxalate crystals form, and if anybody here has kidney stones, they recognize calcium oxalate crystals. Calcium oxalate or oxalate in itself forms a majority of the kidney stones that are out there. There's 4 types of kidney stones. Calcium oxalate is one of them, and this forms a majority of the stones out there. It's usually related to having increased amount of red meat and such that circulates after digestion of a big steak. A person who's got a little bit of a kidney or liver issue will have a buildup of oxalate, and after a period of time it binds with calcium. It can actually form kidney stones. But in this particular case, in the setting of ethylene glycol toxicity, we've got these calcium oxalate crystals that deposit very rapidly in the kidney, not slowly like you would if you ever eaten too much red meat, but very rapidly. And these crystals then do 2 things. One, they physically block all the renal tubules, because a lot of the renal tubules only allow 1 and 2 cells through at a time in their capillary beds. When you get a crystal down there, you've effectively blocked it off. When you get 1 million crystals down there, you've effectively blocked off all 1 million nephrons, and you got kidney failure, which is unrecoverable. Second is, of course, oxalate binds with calcium, and if you've got enough oxalate binding to calcium, your serum calcium levels are going to drop. Low calcium levels produce tetany. High calcium levels produce paralysis or flaccid paralysis. And so hypocalcemia becomes a very treacherous situation, because what happens when you got low calcium? You got prolonged QT intervals. And the prolonged QT intervals, if you remember from your cardiology, one of the differential diagnoses is hypocalcemia, and this can be particularly treacherous. Calcium is required to oppose the action of potassium in the heart. If potassium runs unabated, in other words, there's not enough calcium, then the potassium is going to have more of an opportunity to depolarize the heart. Depolarized heart means VFib, VTAC, and more often than not pulseless, and that's the terminal event, is too low of calcium. So a lot of these patients, especially when you call into my emergency room and you say, hey, this guy ingested ethylene glycol 12 hours ago, and he's shown all kinds of arrhythmia changes, but his prolonged QT interval is huge. I'll order calcium for the patient and a couple liters of fluid to be dumped into the patient right away. So expect an order for calcium gluconate, or more appropriately in the EMS field, calcium chloride, to be given by syringe to bail out some of these patients. And you may also get an AMPA bicarb just based on your physical exam. Physical exam of acousmal respirations, respiratory rates of 36 and 40, trying to blow off the acid out of the bloodstream. Trying to balance your pH. Respiratory system is the first and fastest way to help you continue pH balance in the blood, because you're able to either slow down your respirations and maintain carbon dioxide, which is an acid, or you blow it off. And subsequently, hydrogen ions become a big part of that acidosis process, and you get the metabolic acidosis. Too much acidosis makes myocardium very weak, and you're very susceptible to depolarization from the potassium. So, just in review, look at the slide again, and just know that we've got crystals. They're going to block up the kidney and cause kidney failure. And you're going to, of course, those crystals are oxalate, which are binding calcium, which are going to drop the calcium, which is then cause the potassium to run unopposed in the heart, and you got cardiac arrhythmias as a result. Now, when it comes to catalyzing step, alcohol dehydrogenase, there's only a certain amount of it in the bloodstream. You can only metabolize ethanol for so long, and then you just run out of enzyme. And as a result, the toxic effects of alcohol become apparent. That's why a lightweight, a person who's just started drinking at a young age, or somebody who's never been a drinker in their lifetime, will have very little alcohol dehydrogenase floating around. As you get years and years of experience in drinking and such, it takes more and more alcohol to achieve the euphoric effects of being intoxicated. In other words, yeah, I've got a blood level of 160 or 170 after maybe 4 shots of bourbon. And yet, if I've been doing this for 20 years, it'll take close to 8 shots, because the enzyme alcohol dehydrogenase can be modified based on how much alcohol you have. It produces more, and then the liver starts producing more and more in anticipation of an alcohol load again. This is why it takes alcoholic patients a lot more alcohol than the average person would. If I were to try to drink what the alcoholic patient tries to drink, I'd be dead. Yet they can run around with alcohol levels of 300 and 400 because they've metabolized half of it already. So it's an interesting paradigm, and it's certainly interesting from the standpoint of how the body adapts to certain situations. If you belong to a civilization or a culture which really uses alcohol not so much as a social ritual that we use in America, but as a regular survival ritual, where they have it with every meal, or they have it constantly, or they're constantly exposed to it, you'll find their alcohol dehydrogenase levels are very, very high, and they've accommodated. And as a result, they don't suffer the effects of chronic alcoholism like they do here in the United States. That takes years, and you have to start that pretty much from age 10 forward. That's a whole different issue altogether. But depending on the culture, depending on the experience of the person, there's going to be some alcohol dehydrogenase combat and many of the effects of the alcohol, but ultimately everybody runs out of the alcohol dehydrogenase, and the effects of alcohol take over. Unfortunately, free-floating alcohol in the body it destroys certain parts of the brain, the cerebellum for one. In ethylene glycol, however, since patients do not drink this ritually as a social event every single day, ethylene glycol toxicity is really what matters here. Even though the same enzyme system that breaks down ethanol is breaking down ethylene glycol, the byproducts are different. We get carbon dioxide and formaldehyde with ethanol. Yeah, we get glyoxylate acid, which again gets metabolized into oxalate, which then binds calcium. And it's a whole different pathway of metabolism. And unfortunately for us, from glycolic acid to oxalic acid to oxalate, calcium oxalate, That's terminal for the body. The resultant metabolic acidosis is wicked, to say the least, and they present quite a challenge. Okay, it's a regular common cause of overdose in the United States emergency departments. Now, I use the word overdose here, and that's probably the wrong word. I don't know what the normal dose of antifreeze is, so an overdose would be something abnormal. What this should say, it's a relatively common cause of poisoning in the U.S. emergency departments. Now, I used that in here on purpose because I needed to mind trigger something here. On the National Registry exam, you're going to get a question that has to deal, with the difference between overdose and poisoning. Overdose results from a medication or a substance that has a normal therapeutic dose or a range of normal dose that has a therapeutic effect in the body to either treat or at least diagnose a condition. Poisoning is a substance, no matter what amount that's taken, that has an adverse effect on the body. So if I take Tylenol, 2 tablets by mouth right now, I can cure a headache. If I take 30 Tylenol right now, I can poison the liver, and that would result in death. That's an overdose. That's a true substance overdose. Whereas ethylene glycol does not have a medicinal use, so when you ingest, it's actually a poisoning. I need for you to know the difference between the two because one or both questions could appear in a test question on the National Registry. All right. 5,282 exposures were reported to poison control, probably times 2 that, to actually reported to the emergency room. And subsequently, it remains a fairly significant problem. Interestingly, many of them are children. We've got between the ages of 6 and 19 years of age, if you consider a 19-year-old a child, which if they're drinking ethylene glycol, I would probably consider that to be not intelligent. But you got almost 1,000 people between 0 age and 19 years of age ingesting. But clearly 3,942 of those in 2015 clearly had some sort of exposure. And then these are the actual breakdowns of how that happened. 773 minor outcomes, and then they went to moderate and then severe, and then of course there was 10 deaths. From 2007 to 2014, 106 deaths. So you can see it's not a huge cause of mortality in the country, but it certainly causes a lot of illness. And certainly if the severe outcomes, if they've destroyed their kidneys and go on dialysis permanently, I would call that a severe outcome. Your job as enrolled as a paramedic is to try and save the kidneys as best you can by giving IV fluids into them. And we can talk about some of the treatment a little bit later. But the other thing you have to ask yourself is, how did this happen? Children, pretty easy. It's sweet, looks pretty, they taste it. Adults, they accidentally take a swig because it's in the wrong container, spit it out, no big deal. But what do you do with the guy who's trying to commit suicide, or worse yet, substitute ethylene glycol for regular ethanol? Big issue. All right, so what are you going to do in your history taking? First things first, what did you take? If you strongly suspect ethylene glycol, then it's going to be the timing is the most important thing. If it was within an hour, we got a good shot. If it's within 4 hours, we got a pretty decent shot. If it's been more than 4 to 6 hours, this is going to be a dice roll. And so we really have to not only determine what time he or she took it, but how much they took. And of course, you're going to get called to the scene, and it's going to be 2 hours afterwards, and somebody's going to be hysterical and say, hey, he just drank a half bottle of antifreeze, and the guy's going to say, no, I didn't, I feel fine. And everybody's going to go, oh, okay, and that'll be it. And then you get called back 4 hours later, and of course, you got yourself a pretty ill patient. So what are we looking for? First thing you're going to do is put them on a monitor. You're going to look for that prolonged QT. You're going to check a temperature if possible, if you have one of those forehead measures or tympanic membrane devices that can measure temperature. And you're going to make sure that the airway is secure, because at any time they're going to get altered and they're going to start to vomit. And we all know what happens when they vomit. They aspirate. So second is deep and rapid breathing may be Kussmaul respirations, nausea, and vomiting, which are all indicative of severe metabolic acidosis. If you give me a call as online medical control or as your medical director, if you're on one of the fire departments up here in North County, Texas, you'll find that we're going to start giving a lot of orders in addition to your fluids. We're going to be asking for RSI. We're going to get this patient down. We're going to be dumping a lot of fluids into them. And then here comes your sodium bicarbonate and your calcium chloride. And these are going to be very, very important mainstay treatments. The most important thing is to make sure that you're very accurate with your history and you're accurate with your physical findings here. In other words, you know what you're looking for and you know what you're going to start recognizing here. All right. So let's go over some of the systems that are involved with metabolic acidosis. 3 to 4 hours after ingestion, we're start getting a shaky area. We're going to start seeing altered mental status. At first, it's going to look like your routine, no kidding, ethanol intoxication. Slurred speech, a little confused, cognitive impairment, a little executive functioning, not working so well. In other words, he jumped in the shower, unfortunately, forgot to take his clothes off. Those kinds of things. Those are all have to do with executive function, higher functions within the cerebral cortex. And these are the first affected. Any one of us who have ever had a little bit too much alcohol knows how we feel. There's a period of euphoria, and then there's a period of, I'm not feeling so hot, and you're getting a little altered. And the next thing you know, wherever you end up, you end up. You don't remember much afterwards. And it's the same thing with ethylene glycol. They're going to act like alcohol. So it's going to be very important to make sure that you distinguish between alcohol intoxication and ethylene glycol. It's coming in the emergency room and you bring them in. Oh, you know, we've got our usual drunk coming in again and such. Geez, doc, why do you get all those lab tests? Because we get all those lab tests. We're looking for anion gap acidosis, alcoholic ketoacidosis, ethylene glycol poisoning, isopropanol poisoning, and such like that, because you just never know. And what you can't do out there in the field is put down alcohol intoxication. You have altered mental status, presumed alcohol ingestion based on history, bottle of alcohol found at the bedside, patient admitted to 16 beers. You know, what did you see? What did you hear? But you don't know until we finally get to the bottom of it. Now, I'll give you this, 99% of all of it's going to be alcohol intoxications. But once in a while, you're going to get fooled. And unfortunately, you hope you get fooled in a lucky but good way. And you hope you don't get fooled with a subpoena at your door. For a wrongful death suit. All right, so when we look at head, eyes, ears, nose, and throat findings, the patient's going to complain of tinnitus. Their ears are going to be ringing. Well, unfortunately, it's a part of life, and all of us have some sort of ear ringing, but this is going to be pretty intense. Blurred vision, vertigo. Well, geez, you just described, you know, all 32 million alcohol intoxicated patients that are out there in any given day, especially at New Year's. So these are interesting when they're present, but if they're absent, don't put any weight on it and don't make it absolute criteria. Visual disturbances, including dimming, photophobia, scutamata, and frank blindness. These things happen. Palpitations and chest pain, these things are going to happen as well. The chest pain's curious because generally a person who's drinking ethanol alcohol as a social ritual or just a nightcap and such, generally won't develop chest pain, at least a chest pain that's related to any cardiac issues. Most of their chest pain is related to GI issues, which may cause a certain degree of gastroesophageal reflux or any kind of relaxation of the cardiac sphincter, which is the muscle that sits on top of the stomach, separating the esophagus from the stomach. The cardiac sphincter relaxes and it makes it easier to aspirate. When you've been alcohol intoxicated and you're laying flat on a bed, all of a sudden, sometime during the night, you feel that burning coming up the middle of your chest. Hell, that's acid coming up. That cardiac sphincter, just like your brain, got snowed under. and it can't do its job anymore. It's not holding the acid in the stomach. It's relaxing, just letting things kind of ease into your mouth. Unfortunately, if you're that alcohol intoxicated, you could aspirate that. And unfortunately for you, that aspiration tends to be a very serious pneumonitis, chemical pneumonitis as a result of it. Now, ethylene glycol can give you cranial nerve palsies. Now, even though ethanol can make you feel like your whole brain went numb, ethylene glycol can give you cranial nerve palsies. And most often, it's the ability to move the eyes laterally. So it's going to be cranial nerve 3 and 6. Of course, 3 is going to be responsible for upward movement of your eye, downward movement of your eye, and medial movement of your eye. You could get some trochlear, cranial nerve 4, but it's mostly 3 and 6. The cranial nerve 8, when you're hearing tinnitus, the ear ringing, it's not really a cranial nerve palsy. However, you should be aware that tinnitus in combination with a person who's not able to move their eyes in a normal fashion causes real concern for ethylene glycol ingestion. When you have somebody who's ethanol intoxicated and you have them check extraocular movements, you may get some shaky movements, some what they call nystagmus, but you're not going to get paralysis. And a cranial nerve palsy is a very serious finding. Okay, so lethargy, stupor, coma may occur in severe metabolic acidosis, particularly with the toxic ingestion. That would be the neurological. Down here, cardiovascular, as the acidosis progresses, the patient can get into fatal ventricular arrhythmias. Again, the prolonged QT interval, because of the low calcium. Calcium is not there to oppose potassium. Potassium is a strong depolarizer, and subsequently, your heart just fibrillates, and out of the clear blue sky. Some of your transports to the hospital for patients with late ethylene glycol, paramedics and EMS in the past have described these patients as talking to 1 minute VFib the next, which necessitates the cardiac monitor all the way through. Okay. When we talk about reduced cardiac contractility, this is the same for alcohol. This is why people who are involved in hazing and such, they have to drink a whole bottle of alcohol, become intoxicated. That onslaught of alcohol, especially in somebody who can't handle that level of alcohol and such, actually causes hypotension, congestive heart failure, and that's usually what kills these fraternity people that have to undergo this idiot ritual to drink alcohol. In other words, to prove something. I'm not sure what they're proving. But what they've done is they've inadvertently killed many fine college students as a result of this. And you should know, if you drink a whole bottle of alcohol down, you're not experienced in drinking alcohol. This is what happens: CHF and then ventricular dysrhythmia. And it happens within a very short period. All right, pulmonary tachypnea and hyperpnea is the deep breathing, the Kussmaul respiration. It's an intense, very deep, very rapid. You almost have to sit in the corner and breathe heavy, real hard, real deep. Kussmaul respirations are exactly that. However, it's not under conscious control. Most of these patients, when they start getting into Kussmaul, they have altered mental status, and this is the natural response of the medulla oblongata to blowing off the excess acids in the body. The bicarbonate system in the kidney is completely destroyed by this time. It's exhausted its entire supply of bicarbonate. So the only real acid-base compensatory mechanism you have is adjusting both your tidal volume and your respiratory rate. So real deep breaths at a very rapid pace. And even then, you can't keep up with the acidosis production. Diabetic ketoacidosis patients act the same way. Metabolic acidosis is the end product of particular toxins. Very few toxins can cause metabolic acidosis. Diabetic ketoacidosis is one, so is ethylene glycol, so is isopropanol. I've done that twice. So can methanol. So one of the common ways that people used to die is by this kind of ingestion. They get into Kussmaul, and next thing you know, they just die from the acidosis as a result of the potassium. being unopposed by calcium, which is no longer present. So I think we've hashed that one to death. All right, so here we go. The initial therapeutic goal for patients with severe acidemia is to raise the systemic pH above 7.2. Why do I teach this now? Why do I say this now? Because the day is coming very soon, and we're piloting some of this in North Collin County, where you have instruments that can give you all of this information. Right now, we teach you to stick the finger and put it in a glucometer and look at it, and here comes the number, glucose. We're going to ask you to do the same thing, except the machine's going to be a little bit bigger, and the stick's going to be a little bit longer, but you're going to poke the finger, or you're going to draw the blood, you're going to stick the stick inside the machine, and now you're going to get sodium, potassium, chloride, bicarbonate, sodium, potassium, chloride, bicarbonate, glucose, and calcium, and a pH. And you're going to be expected to act on this. So as future paramedics, your continuing education is going to evolve with technology. Back in the 70s, I thought we died and went to heaven when we finally got this machine called a pulse oximeter. Of course, it was as big as a laptop, and it wasn't really portable. You had to actually get them in the back of the ambulance. Now they got little finger things you can walk all over the place with. Well, it's the same thing with technology in EMS. You got the handheld visual laryngoscopes that can actually visualize the vocal cords, so you're taking the guesswork out. But now you've got iStats, where you can measure 8 different parameters the same way that you measure blood glucose in, you ready for this, the same amount of time. It's not going to add to scene time. Most of your scene times you should be on and off the scene within 10 minutes. You're going to have outliers. We get that. But most scene time should be 10 minutes. This is not going to add anything to it. Once you get the patient in the back of the ambulance, and this should help you expedite patients, get them in the back of the ambulance and get them to the hospital. En route, you're going to be looking at these lab values and you're going to be correcting them. This is one particular case, ethylene glycol poisoning, where this iStat is going to be very valuable to you in recognizing metabolic acidosis, high potassiums, very low calciums, and with the proper history and physical findings, we should be able to competently guide your initial treatment until you get to the hospital. For those of you who say you're only 5 minutes away, it doesn't happen. Never happened. Patient called, it took you 5 minutes to get on the scene. It took you 5 minutes to find them. It took you another 5 minutes to evaluate them, put them on a stretcher, and get them into the position where you can put them downstairs. Another 5 minutes to get them in. You're 30, 40 minutes into this thing already. The patient's condition doesn't start getting worse when you arrive. It got worse when they picked up the phone. And so don't get sucked into some of the laziness that happens out there when we're just around the corner. Yeah, okay, fair enough. But if you're unfortunate, or if you're one of those fortunate paramedics who are being trained to a higher level because you live in a frontier or a rural county in anywhere USA, and your travel times to a hospital could be greater than 30 minutes from the time you pack them up on the stretcher until the time you hit my door, you're going to be expected to be doing these iStats and such. Back to ethylene glycol. Here's an opportunity where the iStat will really become huge. Diabetes, ethanol poisonings, any person that has altered mental status, renal failure patients, overdoses of medications, apoplexy, cardiac dysrhythmias such as torsade, which could very well give you an indication based on acidosis, high or low potassium, and you're counteracting the potassium with magnesium. And of course, you got any of the electrolyte imbalances that can occur with any of the patients who are taking diuretics, calcium channel blockers, beta blockers, and such. iStats are going to be a big part of this, and it's the next thing coming, and it will be here right soon. All right, so you treat the underlying condition. That's the great answer to everything. You know, what's causing the acidosis? This is. Well, then treat that. When you treat that, you correct the acidosis. I get that. You know what? This is EMS. We don't always have that luxury of knowing what's going on, so we have to make sure they don't die first and then we can worry about what caused this whole thing. And so that's the position that you and I are put in as both paramedics as well as medical directors is, what do we do when we're behind the eight ball from the very beginning? And the answer is get as much information as you can. ISTAT could be a part of that. A good history and physical could be a good part of that. Cardiac monitoring, a great part of that. Glucose monitoring for now, ISTAT monitoring later. We got it covered. So embrace the horror. Here it comes, the future. Okay, bicarbonate is unnecessary except in an extreme case of acidosis. What's an extreme case? Anytime that they're starting to show cardiac dysrhythmia, which would be a pH of 7.1 or less. All right, so we run 2 liters in, 1 in each arm, large bore IVs. Here we go, same as a trauma. 0.9 both sides. All right, lactated ringers, lactate. Remember that pH is sitting around 4 in the bag. So adding a pH of 4 into the bloodstream is adding another poison or another metabolic acidosis. So when people say, well, we should just be covering lactate, the answer is no, you just don't carry lactated ringers. You have to carry 0.9. pH is somewhere closer to 6 or 7, but remember pH is semi-logarithmic. So it's going to be 100 times less acidic than a pH of 4, if you understand semi-logs. And most of you probably do. You've been through Henderson, Hasselbalch, and all the other happy stuff that are out there regarding hydrogen ions. So you should be carrying 0.9. If you want to carry lactated ringers for the OB patients, fine. But any system that carries LR without carrying 0.9, have their medical director give me a call so I can assess whether or not they're real doctors. All right. Cardiac arrhythmias are caused by acidosis. The use of sodium bicarbonate should correct the arrhythmia. So if you're starting to show arrhythmia with these patients with a confirmed history of ethylene glycol, or at least a pretty darn good history of ethylene glycol, you're seeing cardiac arrhythmia and Kussmaul, I would order the bicarb. That may or may not be part of your protocols, but you've got that other option. You got $10,000 worth of radio equipment here. Pick up the phone and call one of us in the emergency room. We'll give you the order for the bicarb. If you're calling a competent center that's got board certified ER docs, we'll give you the order for the bicarb. It's the only way you're going to prevent ventricular arrhythmia here from progressing into a lethal ventricular arrhythmia, i.e. VTAC or VFib, which is pulseless. Okay. And then, of course, you've already made a decision for rapid transport. I said this was going to be a short one. I lied. We're running into 50 minutes here already. So watch the obtunded ethylene glycol patients. Know that when they get obtunded, they're going to die, and they're going to aspirate. They're going to make a mess of your ambulance. Best thing you can do for these patients, intubate them. They'll make a mess of the ambulance. They're not going to make a mess out of you medical legally. Okay. So protect their airways at all costs. Once they start getting altered mental status or once they start vomiting, it's best to put them down with a non-depolarizer. Forget the succinylcholine. Remember, we got a potassium-calcium shift going on here. Succinylcholine is only going to make that potassium shift worse. So a non-depolarizer, rock or vecuronium, get the etomidate into them. If you want to use ketamine, have at it. Get them tubed. And then when you obtain intravenous access, if you don't have ISTATs yet, most of us don't, you draw a couple tubes of blood so we know at least where to start. We get a venous gas and electrolytes off any tube that you draw. I mean, it's, if you carry around a couple tubes, just so we know where you've been prior to you starting your IV fluids and such. Okay, activated charcoal, keep it in the box. Epicac, definitely keep it in the box. As a matter of fact, Epicac should probably be thrown out now. I don't know of any competent EMS system, competent EMS system of board certified emergency physicians who are board certified EMS medical directors that allow Epicac in their boxes anymore. We've all been taking them out. We've had them out for 2015. Took them out finally in 2015. You're going to start your 0.9 normal saline at about 500 cc's an hour. I may order, depending on hypotension or whether or not it's there or not, or how far along the patient is in their syndrome, I may order 2 liters to be given over 1 hour, like right away, like dump it into them. This is going to clear and it's going to keep the crystals from forming bigger crystals in the kidneys by having lots of fluids in there circulating around. And perhaps we can even save the kidneys with this flush. Remember, you've already got them tubed. And then bicarb, of course, to correct any acidosis. If they're Kussmauling and they're altered mental status, I'm all over it. We'll give you an order for bicarb. Okay, and then of course, transport. Now, don't transport to the local freestanding ER, and don't transport to the local clinic. My doctor's over here. I'm going to go to this clinic. You have to go to a real deal hospital with a real deal ER and intensive care unit, and preferably one with hemodialysis, because these patients' kidneys are going to shut down, and you're going to need to do that to get dialysis. Now, would I go 60 miles down the road for somebody who's got hemodialysis? No. This is an instance where you can park in a competent hospital, and if they don't have dialysis, they could stick them on a helicopter and ship them once they get them stabilized. In other words, get the acidosis under control and everything. So hemodialysis is a consideration, and if two hospitals are equidistant from each other from where you're at, I'd go to one that's got the hemodialysis with the ethylene glycol ingestion, but it's a thing, but it's not an essential. Okay, and do not delay transport. As a matter of fact, once you identify the ethylene glycol, get them in the ambulance, start heading in. Okay, when can you not transport these patients? This will be the last item we cover, and I promise I'll let you go. The absence of symptoms is not good. That cannot be your determinant for whether or not a patient stays at home. In other words, accept an AMA. A child gets something in, tastes a lick, 10 cc's, they spit it back out, they vomit, and they've been okay. People who took something 24 hours ago, well, we all know ethylene glycol is going to clear within 10 to 12 hours. So if they have any symptoms after 24 hours, I'm going to let them go from the ER. If the patient doesn't want to go and it's been more than 24 hours since they drank ethylene glycol, if they don't want to go, don't take them. It's not something that you have to get an EDO from a police officer and say, hey, look, we got to take this guy. He's got to go. And even then, if he's conscious, alert, and oriented times 4, most police officers aren't going to let him go to the hospital anyway. They're going to say, yeah, they have a fundamental right to stay at home and be stupid. But in this particular case, if it's an accidental one, they just got to swig and spit it out and such like that. These aren't people that we were really interested in the emergency department. However, if there's any questions, call. Get it on the recorder, get it on tape, get Frame's name on the recording and say, hey, this is what was described to us by the patient. What do you think? The patient doesn't want to come. I'll accept the AMA. It's not a problem. And we don't have to EDO these people. All right, we are at the end of the slideshow. Ethylene glycol is testable. It will be tested on your National Registry exam. It may be anywhere from 1 question to 3 questions. And it's mostly going to have to do with the toxicology and the pathophysiology surrounding it. Fluids, bicarb, calcium, prolonged T waves, all a big part of ethylene glycol. Most importantly, the metabolic acidosis. But watch the pathophysiology of ethylene glycol. All right, does anybody have any questions? I like your question, Brenda. Calcium oxalate is the toxin in houseplants, the dumb cane. Want to do the same thing in that case? Toddler chewing on a plant, developing symptoms. Yes, absolutely. Get them in. Get them in. Another thing that's poisonous to children as well as pets is what's that big Christmas flower that everybody, they're big in red or they're big in yellow. It slips my mind. Anybody remember? Poinsettias, that's it. Jonathan, thank you. Yep, Brenda, you got it too. Poinsettias, highly toxic to children and to pets. Unless you're got good control over everybody and they're not going to crawl up to the poinsettia and start gnawing on it, I keep them out of the house. If they're pretty and you can keep everybody under control, have at it. But they can be poisonous to both children and the pets as well. Whether it's the same mechanism here or not, I never took the time to really look into it. I probably should. All right, if everybody's good, and I can see that everybody is good from here, if you have any if you have any questions, you can email me. I'm going to give it to everybody here right now. If you want a copy of these slides, I'm happy to post them on the, well, wait a minute, they belong to PERCOM. Yeah, they'll be on the PERCOM website. But if you have any questions or comments, you got any private questions or comments, fire them off at jeframe@comcast.net. I'll get to them as soon as I can, but I do promise you an answer. And if you guys have nothing else, I think we're going to go ahead and terminate. So y'all have a good evening.